Okay, Agnivesh, I hope you can see my screen. Is it okay?
Yes, we can see, sir. Yeah, please make it full screen. So,
Okay. So at the outset, let me thank Dr. Siddhartha Yadav, Dr. Agnivesh Tikku for giving me this wonderful opportunity to, present. We have all sorts of webinars, but this initiative by the team Apollo is really nice for postgraduates. And I will be speaking to you about examination of lower limb deformity. So, guys, deformity is a pretty common short case in your examinations. So you have all sorts of cases, but the common ones are genu varum, genu valgus, and Dr. Ghani has actually done a very good job of summarizing how you should approach your case. So in a short case, you have to come on to the diagnosis and the common scheme. So I've seen many examiners, but the common thing between all short cases is the first thing that you will be asked is, what is your diagnosis? The second question is, why do you say that this is the diagnosis? The third thing is, what are your differentials? And the fourth thing is, how are you going to manage this case, right? So the diagnosis part of a deformity case is easy if you ask me. Now, most of you know what a genu varum or a genu valgum or even a procurvatum or a recurvatum deformity looks like. By the time you're in your third year, you've seen. But then there are more aspects to it, and by means of this lecture, I want to tell you a general scheme. So by no means is this a fixed way to examine your case. You follow whatever scheme of examination you've been following so far, but the idea is to give you an approach to a deformity case, and this you can incorporate into whatever scheme of examination that you've been using. So let's look at this approach now. So whenever you see a deformity, you have to ask yourself the following things. So the first thing, especially if this is a child, of course, is whether this is a physiological variant, and I will be telling you about this. The next thing, which is the easy bit, is to identify the plane. Then you have to identify the site of the deformity, go ahead and quantify the deformity, determine the effect on adjacent joints. If it has an effect on gait, you have to see that, and determine the etiology. Now, mind you, by no means is determining the etiology the least important thing. So like I said, this is a general scheme, and you can build this into your own system of examination. So let's look at the physiological variants. So especially when you have a young child, you need to know what are the physiological variants. And you have variants that can exist in the frontal plane and also in the axial plane. So at birth, if you have ever seen an infant, I'm sure you have, you will notice that most of the infants have a physiological varus. Now, this can be, mild or moderate in intensity, but almost all infants have some degree of varus. So by 18 months, or by some textbooks, 24 months, this varus will convert into a neutral alignment, right, which we call as rectus. After this, the alignment changes from rectus to valgus. By 4 years of age, you have a maximal valgus. This valgus then starts decreasing, and usually by 7 years or 8 years of age, different textbooks, you have the adult values. So when you talk of physiological varus, remember Carlos Santana. I don't know if you heard the song Smooth. It was a super hit track. But here's the deal. So physiological varus is smooth, Most of the times you see it below 18 or 24 months of age. It is bilateral and it involves all parts of the femur and tibia. So that's what I mean by smooth. It involves the proximal third, the middle third, and the distal third. So, and there is an even varus and it involves both the femur and the tibia. So guys, please remember this. Now then, what is pathological varus? So any varus after 18 to 24 months of age, you should consider as pathological. And remember the 4 S's. So sharp varus, as you can see here, this is a toddler with Blount's disease. So sharp angular varus of the tibia, as you can see here. Severe varus even before 18 or 24 months of age. And now this varies by different textbooks, but any varus more than 20 degrees, single, that is unilateral varus, So remember smooth, anything which is not smooth. And finally, varus that is associated with short stature or other stigmata of genetic disease or metabolic disease. So when you have all of these, please think of pathological variants of varus. Now you can have pathological valgus as well. So valgus more than 12 degrees. Now mind you, 12 is a cutoff figure. 13 does not necessarily mean it is abnormal. You have normograms for this, but as a general rule, any valgus more than 12 degrees or an intermalleolar distance more than 8 centimeters after 7 years should raise suspicion of a pathology. Also, if you are having progressive valgus, so if you were following up the child and the valgus is increasing on each visit. Finally, valgus after trauma, and again, if you have stigmata of the genetic syndromes like short stature or metabolic syndromes, you should be very wary of a pathological valgus. And remember, a very favorite examination question is the Cosen's fracture. I'm sure you know of this. Now, this is valgus which happens after trauma, right? So like you have variations in the frontal plane, you can also have variations in the axial plane or the torsional plane. Now, many toddlers will come with in-toeing gait. This does not necessarily mean that this is pathological. And how do you evaluate torsion? Well, I have covered this up in the subsequent part of the talk also, but briefly, you should look at the overall alignment by means of the foot progression angle. Look at the hip as a cause by looking at the Craig's test and the rotations. Look at the thigh foot angle and the heel bisector. Now, mind you, we'll come back and look to this again. So having dealt with the physiological variants, let's see which plane the varus is. Now, this may be the easiest part of the examination and something that you already know. So the deformity can exist in a frontal plane, sagittal plane. Sometimes it can be a plane between the two, which we know as the oblique plane. I will show you. And of course, there can be an axial plane deformity. So the frontal plane deformities are varus and valgus. And now you see this deformity is in the plane of your screen. So this is a frontal deformity. And since the medial end is going, so if this was the left side tibia, this would be a valgus deformity. You know this. Now the sagittal plane deformity again is easy to pick up. Now deformity which has an apex anterior is known as a procurvatum, which is apex posterior is known as a recurvatum deformity. Now what is an oblique plane deformity? Now an oblique plane is a plane which is in between the frontal planes and the sagittal planes. So when you see this case, it will have angulation both in the frontal plane and the sagittal plane. So if you were to take an AP and a lateral radiograph, you would see angulation both in anterior-posterior and the lateral radiographs. Please do not say that this is a biplanar deformity. It's just that the plane of the deformity lies in between the frontal and the sagittal plane, as you can see here. And then there are ways to determine what is the oblique plane and what is the magnitude of the oblique plane deformity, but I'm not going to touch here. So remember, there can be an oblique plane deformity which is in between the frontal and the sagittal planes. Now the axial plane deformities are torsional deformities, and we will talk about this. So once you identified the plane, you should next try to identify what is the site of the deformity. So by site, I mean you have to identify whether the deformity in a lower limb is in the femur or the tibia. Perhaps it could be in both. And if it is in one of these bones or both bones, whether this is an intra-articular or an extra-articular, whether it is metaphyseal or diaphyseal. And let's look at this one by one. So if you wanted to identify whether the deformity is in the femur or the tibia, especially if this is a valgus deformity, you would do what is known as the flexion test. And again, this is a favorite of the examiners. Many of you must already be knowing this. So basis of the flexion test is the anatomical articulation of the femur with the tibia. Now you know that the distal femur in full extension articulates with the tibia. So the distal femur in full extension articulates with the tibia. However, when you flex the knee, it is the posterior part of the condyles that articulate with the tibia, right? So if you had a femoral deformity like this, so this case only has a femoral deformity. Now in full extension, the tibia is going to articulate with the distal femur and the valgus deformity will be apparent. However, in flexion, it is going to articulate with the posterior femoral condyle. And mind you, the posterior femoral condyle is normal, so the deformity is going to disappear. So an isolated femoral deformity will disappear in flexion. Please remember this as the femoral test, right? Mind you, if there was a deformity of the posterior tibial condyle also, let me go back to this slide. If there was a deformity of the posterior tibial condyle, this test can be falsely interpreted. So this is one of the prerequisites of the flexion test. You should have no deformity of the posterior femoral condyles. Now let's see what happens when there is a tibial deformity. So here is a case where you have a tibial deformity. So in full extension, the deformity is apparent. When you flex the knee, because the deformity was in the tibia, so it does not matter whether the tibia is articulating with the distal femur or the or the femoral condyle, the deformity is going to persist. The magnitude is going to remain the same as it was in full extension, right? Now what happens when you have a combined deformity? Now see, this case has a deformity in the femur as well as the tibia. So the femoral part of the deformity is going to be masked when you flex. So the magnitude of the deformity will decrease. However, the deformity will still persist. So please remember the flexion test. Now talking of the anatomical site of the deformity in a particular bone. So how can you differentiate this? So there are some ways. First is the progression of the deformity. So diaphyseal deformities, as a general rule, are static. Metaphyseal deformities can increase or decrease depending on whether or not they involve the physis. If they were to involve the physis, if there is a physeal arrest or an asymmetrical growth, it could worsen or it could remain the same. If it was an adult with a metaphyseal deformity, intra-articular deformities, on the other hand, always tend to increase because of abnormal joint loading and joint destruction. Now let's see what is the limb length discrepancy. Now in diaphyseal as well as metaphyseal deformities, you can have mild to moderate limb length discrepancy. Again, if the physis is to be involved in a metaphyseal deformity, you can have moderate to severe. On the other hand, in an intra-articular deformity which involves the physis in a child, you will have severe deformity. Of course, if it is an adult, you will not have much limb length discrepancy. Now, what about the joint range of motion? In a diaphyseal deformity, by default, this should be normal unless you have a soft tissue contracture. In a metaphyseal deformity, now this is very important, the arc of the motion will be altered, but the overall range will remain the same. So if you had a flexion deformity of the distal femur, you will have more flexion, less extension, but the overall arc would remain the same, right? But in an intra-articular deformity, this is very intuitive. It is going to be painful and restricted. Finally, what is the effect of joint motion on deformity? So for a diaphyseal deformity, of course, there is going to be no alteration. Now, a metaphyseal deformity, if it is in the plane of the movement of the joint motion may affect the appearance of the deformity. So if you had a flexion deformity, let us say, so moving the deformity, is going to make it more severe, and then vice versa. So now let's go ahead and move to the next step, which is quantification of the deformity. So how do you quantify a frontal plane deformity? So this is done with the patient in the standing position. And guys, please remember, this is always done with the patella facing forwards and not the foot facing forwards. Now here is a child who is standing normally, and you would think that he has maybe a normal alignment or a mild valgus, but notice that the patella is facing outwards. And now when the patella is facing forwards, you see that there is an exaggerated valgus. So this is the difference between a foot forwards position and a patella forwards position. So please remember to examine the child in a patella forwards position. So when you make the patient stand with a patella facing forward position, there are three possibilities. So the thighs may slightly touch each other and the malleoli may just touch each other. So this is a rectus alignment, which is completely normal. The other bit is that the malleoli may touch each other, but the femoral condyles are separated. This is a varus alignment, and you can quantify this by the intercondylar distance. So normally the intercondylar distance should be 0, or in some textbooks it is mentioned up to 5 to 6 millimeters. You can also quantify this by measuring the long axis of the thigh with the leg or the thigh leg angle, right? The third possibility is that the inner thighs may touch each other, but the malleoli are separated. This is a valgus alignment, and this is quantified by the intermalleolar distance. And like I told you, after 7 years of age, anything more than 8 centimeters is considered abnormal. Now, mind you, there are variations. There are normograms available. And for recruitment purposes, there is a handy guide which tells you what should be the normal intermalleolar distance. Of course, you can also quantify this by measuring the long axis of the thigh with the long axis of the leg. Now, a sagittal plane deformity, you have to see the patient from the side, otherwise you may miss it completely. This is a patient who has a recurvatum deformity, and again, you can draw the long axis of the thigh and the long axis of the leg and quantify the deformity. So for torsional deformities, the foot progression angle tells you what is the overall deformity. Now, the torsional deformity may be at the level of the femur, the tibia, or even at the level of the foot. So let's look at this one by one. So the foot progression angle is the angle formed by the long axis of the foot with the midline. This is usually 15 to 20 degrees or a maximum up to 25 degrees. Variations exist with age. So, but this tells you the overall rotational alignment of the lower limb. The hip is quantified by measuring the Craig's test, which you have seen in your hip examination. You can quantify the anteversion. You can also check the medial rotation or the internal versus the external rotation. The internal rotation is always more. The tibial torsion is quantified by measuring the thigh foot angle. As you can see here, you have to make the patient prone, and the long axis of the thigh and the long axis of the foot tell you what is the torsional deformity at the level of the tibia. The heel bisector tells you what is the deformity at the level of the foot. And here is a normal looking foot, valgus foot, and these are variations of metatarsus adductus. So the torsional deformity when it comes from the foot is quantified by the heel bisector. And mind you, this is the Bleck's grading of the metatarsus adductus. So having quantified the deformity, the next step is to see what is the effect on adjacent joints. And we have already looked at this. Diaphyseal deformities do not affect the range of motion. Metaphyseal deformities change the arc. Now this is, the analogy would be similar to a supracondylar humerus fracture, which changes the shoulder range of motion, but not necessarily the total range. So the arc of motion is changed, but the range of motion is not changed, right? Intra-articular deformities, of course, there is going to be a painful restriction of the range of motion. Finally, you have to look at the effect of the gait, and gait by itself is a big topic. So 3 important things when you talk of lower limb deformities is a varus thrust gait, a valgus thrust gait, which you see with a valgus deformity, and a recurvatum, which you see with a recurvatum deformity, right? And here is one example of a varus thrust gait. So look at this gentleman. So as soon as this gentleman goes into a stance phase, now because his overall limb alignment is varus, when he bears weight on it, the varus dynamically increases. Now this is because there is an abnormal loading across the joint and the varus is going to increase. So I'm going to play this video again for you. In this position, the lateral joint line is going to open up and you are going to see this opening up as a thrust. So look again, look how beautifully this joint line opens up on the lateral side and you can see this as a thrust. Okay. So the last but not the least, to look at the etiology, and the etiology can be varied. I'm just going to touch it very briefly. So the etiology could be trauma. So of course, in your history, you have to ask for a history of trauma, infection. I already talked about pointers for metabolic disease. If you had rickets, you would be looking for chest wall abnormalities, skull abnormalities, problems with dentition, hypotonia, and other things. You know, the double malleolus sign, the rachitic rosaries, and depending upon the age, you would have specific sign of rickets. You already know this. So again, remember in your general physical examination to look for short stature, abnormal facies. Remember to have segmental length measurements, especially if you are dealing with a pediatric deformity case. And once you are done with this, like Dr. Ghani said, you have to wind up your examination by looking at the distal neurovascular status. Remember to examine the spine, hip, knee, ankle, foot quickly to see, because the deformity may be a part of a generalized disorder. And remember that knee deformities can be associated with foot deformities, hip, and vice versa. For example, a valgus knee malalignment can be associated with pes planus and also with patellar instability. In fact, many patients with patellar instability will also have a severe degree of valgus, and you have to tell this when you present the case of patellar instability. Now, bowing in children, this is a very important slide. And bowing in children can have three broad important causes which you should be aware of. You have anterolateral bowing, anteromedial bowing, and posteromedial bowing. And I'll go over this table very slowly because it's so important. So anterolateral bowing is pathological, is usually caused by congenital pseudoarthrosis of tibia. Anteromedial bowing, on the other hand, is caused by fibular hemimelia. Posteromedial bowing is physiological, but mind you, it does have long-term consequences. Now, bowing in all three cases happens in the middle to distal third, but in the anteromedial bowing, it is usually in the middle third. Now, genetic association, you know that for congenital pseudoarthrosis, it is with neurofibromatosis type 1. Anteromedial bowing is associated, or hemimelia is associated with the sonic hedgehog gene. If you look at the associated abnormalities, anteromedial bowing is associated with ankle instability. Fibular hemimelia has typical presentations. You have limb length discrepancy, lateral toes may be missing, genu valgum, knee instability, equinovalgus foot, and tarsal coalition. Posteromedial bowing is typically associated with a calcaneovalgus foot. Now, possible long-term sequelae, if untreated, anterolateral bowing leads to recurrent fractures and a limb length discrepancy of 5 centimeters at around skeletal maturity. Remember, this is a favorite examination question. Anteromedial bowing, you have variable amounts of length discrepancy, which depends upon the severity or the grading of the hemimelia. Posteromedial bowing is associated with 3 to 5 centimeters of discrepancy. So that's why I said, even though this is considered as physiological, but it does have some long-term consequences. Now, this is an infant who has a posteromedial bowing, and notice the typical equinovalgus positioning of the foot. This is a child with an anterolateral bowing of the tibia, which is so typical of neurofibromatosis. So to sum up, guys, please remember the approach. Remember to look at the variants, identify the plane, site, quantify your deformity, determine the effect on the adjacent joints and the gaits, and please remember to look at the etiology. Thank you.